Chairman, thank you. Mr. Whitty, thanks for being here. And there's a lot of conversations happening around this dais. I appreciate our phone call that we had a couple of days ago just to be able to talk through some of these things in greater depth. I do want to tell you a story getting started that's I'm going to combine several people together just to be able to tell you a story for an Oklahoman that lives in a rural area. She's in her mid-70s. Several years ago, she used to go to her local physician, but that local physician practice has closed down because of just the administrative burden. They couldn't keep it going. So now she drives to a hospital. It's about 30 minutes away to be able to meet with a doctor there. The hospital and that physician is on her insurance. She has Medicare Advantage. But by the time she actually scheduled an appointment, she actually lined up the appointment and found out, no, they just switched off. They're no longer on Medicare Advantage. But they were when she originally signed up for the plan. Then when she finally goes to the doctor on that, she gets there. The doctor needs to run some tests, but she can't get the test done that day because they have to do a prior authorization with the insurance company. So she has to drive home. When it's a test that she needs, they could do that day, but they can't do that day because they're waiting on prior authorization to be able to go through. The hard part is 2 years later, that hospital has just stopped taking Medicare Advantage at all, as we've had several of our hospitals do in Oklahoma, saying that just the realized reimbursement is 20% less than Medicare. They just can't keep up with Medicare Advantage because all the prior authorizations and because all the denial of service. So they just stopped taking Medicare Advantage entirely, which for her really puts her in a difficult spot. She goes to her local pharmacist that she's gone to for years and finds out that there's pretty remarkable pressure on them and they're going to have a hard time. They're not sure they're going to be able to stay open. But her insurance company tells her, hey, we want you to do mail order pharmaceuticals, but she has pretty complicated chronic diseases and she wants to have somebody that she can talk to. I wish this was a story that wasn't true, but it is. And it's the complications. Now, you've been engaged and United's engaged in all of those areas, both in the PBMs, both in Medicare Advantage. This is not a story just on United. This is just a reality that we're facing here, especially in rural areas. And in my state of 4 million people, 2 million people live in an urban area and 2 million people live in a rural area. So it's a reality for those folks that live in a rural area of those exact challenges that I laid out. I'm not asking you to answer all of those. I guess I'm just saying those so you'll hear it, because that really is a reality of what's happening on the ground every day in rural Oklahoma. And they're just want to get health care and want to just be able to get access to that. I do want to clarify something you and I talked about. It is when hospitals and pharmacies will be made whole after all of the issues of the reimbursements when everything's done. When is that target time when everyone will be made completely whole?
Senator, thank you very much. Just on your first comment, if I may,
Sure.
I'm 100% aligned with the aspiration you described there in terms of how we can help modernize the system. And clearly that is not for one company, and it's a government, state, company obligation. We do need to reduce, for example, burnout of physicians. We need to make it easier for seniors like the lady you described in Oklahoma to navigate this system. We need to be able to provide that help. And we need to make sure that the system is timely and responsive in how it helps those folks so that they get access as quickly as possible. That's what drives every single person at United to try and improve. And we are very open to ideas and suggestions of how we can improve. That's why, for example, just in the last year, we've eliminated 20% of all of the prior authorization codes which existed a year ago. Right. So I just want to reassure you of our commitment and our sentiment to do exactly what you're looking for in terms of helping to streamline the system.
It'd be very helpful. And I know, as we've talked about offline as well, there are families that they do sign up with a specific plan because they know their physician and their hospital is in that plan, and they sign up in October, November, but when they make their appointment in January or February, they suddenly find out, no, that just switched. It switched over in January, though they signed up for it in October. They need to know that if they sign up for a physician, that physician's going to actually be there.
I certainly agree with you, sir. And provider directories is one of the key areas which we all need to try and work together to be better at. In terms of making whole, we continue to make sure that the interest-free loan funding capacity remains available for people all the way through completion of this, and we'll work with individual providers on other issues that they're concerned about.
What do you think is the date when everyone's made whole?
I would hope that that's in the next month or 6 weeks.
Okay. That'll be helpful for all those providers. You and I can talk later on this one, but any specific ideas on the other side of this that the FBI can have? As you know, I serve on the Homeland Security Committee as well as here on Finance, so I'm dealing with both sides of this ransomware attack. Things that the FBI could have done better, things that would have been more helpful proactively or information, that would be helpful. So if any of the folks in your company want to be able to pull together a list, that we can help work on that side of it as well.
We'd be very happy
Thank you.
to.
Time